Okay, so this is a session, the first session, basically on imaging, but we've done two other ones, but we're doing it out of order. So this one basically connects to the paper that some of the papers that I sent you, and we're just going to kind of go over some of the basic imaging that we see for this particular lecture. So the two that you guys are pretty used to, or rather one you're used to, and then one you're getting a handle on are wide field imaging and OCT angiography. So the one thing that give me 1 second, okay? Just give me 1 second.
Sure, no problem.
Okay, there we go. So the two things that you guys are focused on is the wide field imaging and OCT angiography. So what I wanted to kind of go through is sort of both of those modalities as well as ultrasound, so we can kind of understand how they work. So remember, this is basic for you. Just know that like this is actually not, wide field imaging is not wasn't standard until like maybe like 5 to 7 years ago, where everyone started having an Optos. Before that, an Optos was like the new thing. Like when I was in fellowship, Optos had just come out and it was like the new thing. Not everyone had wide field imaging. So it was important to kind of know what its limitations were and what it was. So wide field photography, of course, it permits imaging to the periphery. The new thing that you guys are dealing with now is OCT angiography. And that allows for viewing of the vasculature in terms of the flow and that sort of thing, but without the fluorescein angiography, the thing you have to do where you inject dye, that kind of thing. So that's a very big step up from that, because patients can have adverse reactions to dye and other sorts of complications. It's actually, it takes a lot longer. So it's always good to have an advance on that. So let's go through wide field photography first. The one is Optos because it's the one that we have. They call it ultra wide field because it means it's 150 degrees of viewing now, or anything that's greater than 150 degrees of viewing. So now what is 150 degrees? Well, 180 degrees would mean that I could see to my left and my right, like that whole sphere, the half sphere in front of me. So 150 degrees is sort of approximating that, but still leaves, 15 degrees on either side, a wedge that you wouldn't be able to see if you were right at 150 degrees. So Optos claims that it actually sees 200 degrees, which if you think about what I just said, in a circle, if I were standing at the center of the circle, it would mean that I was able to see behind me. Does that make sense? Like behind me, you get what I'm saying?
Yep.
Yeah, but we don't think that's true in practice. I mean, maybe in some cases it's true, but it's likely around 160 degrees, but 160 degrees is still pretty large in terms of a sweep. Now remember, the Optos is a scanning laser ophthalmoscope. So it is not your standard white flash. What is a scanning laser ophthalmoscope? It means it uses laser. Okay, so it uses laser to reflect a beam back. Laser tends to be a coherent beam on a single wavelength. So when you have a white flash, like a normal camera, that's all the wavelengths in the visual spectrum that you're shooting out at some object when you take the photo and you press the flash button. And then the reflectance, again, we're going back into this reflectance kind of situation like we did with OCT, but even if photos like this, the reflection kind of back is sort of what all those wavelengths, all that pattern that comes back, that's what an image is. And so when you use a laser, you're eliminating quite a few of those actual wavelengths. In fact, you're eliminating infinite amounts of them in favor of one coherent wavelength beam. So just again, laser is not your standard white flash photography. So the one that Optos uses, they have a couple. One is green, which means it does not have red. It's 532 nanometers. If we remember how light works, or any wavelength works, you have a length of a wave, and in this case it's 532 nanometers, that when we look at it or we see that wave bounce off of it, it tends to be viewed as green by the human eye. So that's green. And then you have the red wavelength, which is a longer wavelength, and that's 633 nanometers. And that, if you look at these two, the different wavelengths can actually penetrate and bounce off of different structures because the wavelengths themselves have a kind of a propensity to change the way they reflect off of things by virtue of the fact that they're different lengths in terms of the wave. So green tends to bounce more off of the anterior retinal structures, and red tends to bounce more off of the choroidal vasculature. And so when you combine them together, which is what you see on the Optos image, it forms a facsimile of a color fundus photograph in quotes, but it is not. It's literally they're playing around with the colors, these two wavelengths, and they're trying to create this like sense of an image. Does that make sense?
Yes.
Okay, so thus it is not a color fundus photo. When we say color fundus photo, I mean, I'm talking technically. When you bill for it and stuff, yes, it can function as a quote unquote color fundus photo. But when we say color fundus photo, you have other machines like the Topcon, which is like an actual white flash, but it only gets the macula that will show you a color fundus photo, like a white flash that took a picture of the retina, and it gets all of the information of all of the wavelengths of light in the visual spectrum reflecting back, and that's what you see as a photo. This is not that. So just keep that in mind, okay? Now, let's go through degree of field so you see what it is. Here's these three different images that I'm showing, which show three different degrees of field. This one's 20 degrees, this one's 35 degrees, and this one's 50 degrees. You can see as we zoom out, the wedge that hits that we get of the retina, as we pull out our camera, we see bigger and bigger degrees, okay? Now, here's one interesting point. When you look at this over here, this is a wide field, as you see. This is our 200 degrees. We think it's 160, right? But take a look at this over here. This right over here, and I gave you a paper that showed this. These are your standard ETDRS fields that are subsumed by ultra wide field imaging. Now notice, look how small of an area the ETDRS standard fields are when you compare it to how much retina we actually have. So if we move to this photo here, if you looked at this photo, for us, because we have wide field fluorescein angiography in this case, we're able to see, when I show you this, we're able to see over here that there's NV. But if this were in the landmark trials from the 80s, where ETDRS, the early treatment in diabetic retinopathy study, the stuff that's in your book, if they had this patient, they would probably say that this person does not have NVE and would not qualify in maybe for laser. Whereas we are obviously saying this person needs laser. So do you see how there's a difference?
Yeah, absolutely.
And it's a big difference. So just keep that in mind. Now, mind you, the reason why they did that back then is because they did not have this technology, right? And we still had to treat diabetes, and they needed a standardized way to do it. So they really, really focused on the macula because that's what their capabilities were at the time. And you'll note there is no anti-VEGF, there's no OCT in those studies because they weren't invented yet. So just keep that in mind, that if we reran those studies today, we might, well, certainly we'd change how we treated patients, but we might even change how we diagnosed them. And that's a big deal because when you look at the outcomes of those trials, you know, they could be different because of this, right? You could have patients that are like this. So this shows you obviously the benefit of wide field, but I just want you to keep in mind that the studies that you use that are, you know, dogmatic kind of things we put in print that you have to read, they have these sort of situations that you have to keep in mind, and it sort of gives you more context for why things are the way they are. Here's, of course, another reason why we like wide field, right? You see here, there's NV and diabetic retinopathy that you catch outside of the standard ETDRS fields. And then this is, of course, sickle cell, well, not of course, but this is sickle cell disease with peripheral non-perfusion, but you can see with, of course, your fluorescein angiography. So, of course, wide field photos are great, and we agree with that. What are the limitations? Well, poor posterior pole resolution compared to standard fundus photos. Why? Because again, I told you, when we do our wide field, and that's what most of them are, they use a laser. They don't use standard white flash. So of course, you're not going to get the best resolution because you're not getting all of the tools that the white flash gives you by it bounces off and gives you all the information of the macula. On the other hand, when you use your scanning laser ophthalmoscope, what are we using that for, this photo? We want the wide field, right? That's why we're using it. But if you have something in the macula, it's not ideal for the macula. No matter how much you zoom in, it's never going to be as good resolution. So if you have something in the macula, you might want to get the Topcon. And we actually showed a photo. This was actually a presentation at FA conference once, where you see a branch retinal artery occlusion that literally does not look like anything. It looks like it's not even a pathology on the Optos, but then you do the white, the white flash topcon, which is just the macula, and you see it obviously. So just keep that in mind. It's for posterior pole, because that's all the cameras can get the posterior pole, which is the macula. It has poor resolution precisely because it doesn't have all of the wavelengths of light that it's using. Does that make sense?
Yes. Did you mention how many degrees the standard fundus photo can give you?
Good question. Normally it's around 50, right? And so, you get these, and then when you move it around, right? So you do your standard, like this ETDRS. I believe the ETDRS was classified at 30 degrees, and then they moved it in seven different locations to create that kind of sideways Mickey Mouse sort of image that you saw, where they're all connected. In this case, I think it's 50 degrees, but of course, when you do a montage, you can get kind of those 7 standard fields, maybe a little bit wider. Make sense?
Yeah. Okay.
So the other thing this about the Optos is that the inferior and superior zones are not seen as well as the temporal and nasal because of the eyelids, right? So that's another thing to keep in mind. Also, it does not necessarily image aura to aura, despite the perception that it does. This is why you still need to look and depress, okay? And then peripheral resolution is poor, partly because in general, the resolution is not going to be great with only, a dichromatic, so to speak, laser, technology. But at the same time, we're not looking to get amazing resolution. What we're trying to see is, is there a tear? And then you look with your own lenses, which gives you stereopsis, right? So remember that we don't want to use it in lieu of a exam when we can do it, but it's always great to have because it obviously picks up things that we may not see, especially when it comes to fluorescein angiography and that sort of thing. Okay, so now let's go to OCT angiography, which is, the new kid on the block, and it's something that it's good for you to know. So one of the things that obviously, is that it's like fluorescein angiography, but no dye is required. So this is like amazing, right? I mean, we love that. That's already a win, and it's an advance, but it also, so it's an advance, but it's still restricted. At present, we can only do an OCT, and this, OCT sweeps really are only the posterior pole, just basic OCT, and maybe some places kind of, if you swing the OCT machine, almost the way we did for the white flash regular photography in the past, that's kind of where we are with OCT. There is something called swept source OCT, which is basically an OCT that can sweep all the way like really far to the periphery, not so far as wide field, but like further out than you ever could have hoped. But they don't have angiography for it. So that's not there yet. But so thus this is restricted to the macula and its surrounding structures at present. But remember, it can image depth just like OCT. It's a cross section. So our fluorescein angiography is en face. So you're looking at it the way you would look at the wide field imaging that you just saw, that you're used to with Optos. You're looking at it, and you're looking at a top-down approach, but you're not getting a cross-sectional analysis. And what OCT angiography does is it gives you the cross-section, because OCT gives you the cross-section. So you're able to see flow in areas, in the depth of the retina that you couldn't see before. So that opens up diagnostic ability in a way that maybe we didn't have before. But I want to talk about how it works. So this is going to combine kind of B-scan and OCT. Were you able to read or at least skim this paper? Do you remember this paper?
Yes.
Okay. This paragraph I want to go through because it's kind of confusing, and it's sort of like the flyover paragraph is what I always say, right? It's in the materials and methods. You're kind of like, unless you understood it. When I first read it, it's like, oh God, okay, I'm just going to pass through it and let's figure out what the clinical correlation is. But I think it's instructive to go through this. So we're going to parse this paragraph, okay? Which is like a lot of stuff, but we're going to go through it like quasi sentence by sentence, okay? So the first one is we're going to talk about is this first line, which says this instrument has an A scan rate of 70,000 scans per second. Okay, so what does that mean? So let's go and talk about what an A scan is. Now, mind you, one of the best parts about this particular lecture is that both the ultrasounds that you use and OCT are basically the same technology, but the former uses sound and the latter uses light, but they act the same. They're both things that have a wavelength that bounce off of things. And then we determine what that reflection pattern is. So when we say A scan, what does the A mean? It's not like A means the first scan and then B scan means the second scan, although it worked out that way. A means amplitude. So what does amplitude scan mean? So this instrument has an A scan rate of 70,000 scans per second. What does it mean exactly? So if we think about OCT, again, light reflectance to form an image as ultrasound, this is instructive. So let's look. Have you ever seen an A scan before, Giselle?
Not yet, no.
Okay, this is what an A scan looks like. Okay, it literally has these peaks and stuff. Okay, now let's go ahead and overlay the eye on that. So if you imagine here, right here, is a probe that's emitting. Okay, this is your ultrasound probe, or you could even say then this is an OCT, which inside the OCT machine, there's something that kind of looks like this that shoots out a wave of your choice. We're doing ultrasound, so it's a sound wave, but if it was a light wave, it would be the same exact principle. It would just be a light wave. It's shooting it out and it's going through this, and then it's receiving something. So I'm going to say this is doing 70,000 of these scans per second. Okay, these scans. Now, let's see what, 70,000 of these scans per second. Let me just see what. Yeah, 70,000 of these scans per second, right? Okay, good. So that's that. That's what it's doing. It's doing 70,000 of these types of scans per second. The light goes through and it actually bounces. And actually, let me just see, Giselle. I actually thought, let me just do one thing while you're sitting there. Sorry, I'm going here.
I actually have seen an A scan. So this is like what we use, one of the tools that we use when we're doing ultrasounds and we're determining if there's a retinal detachment, right? We put that A scan over it to see if it spikes the same way.
Well, exactly. But you're kind of seeing, you have an A scan that's overlaying what you guys call a B scan, right?
Right.
And so, that's what we have. But one of the things I'm just trying to figure out here is I actually had a nice, well, okay, so maybe that's 70,000 scans of these per second. Okay, let's just keep going. Okay, so you've seen that. Okay, now each B scan contained 216 A scans. Okay, so we're going from A scan to B scan, and you have an amplitude scan, and you're going to a B scan, but B doesn't stand just for the second one. It stands for brightness scan. So let's convert the two. So each B scan contained 216 A scan. What does this mean? So here is the same exact thing that you saw. We're going to go ahead and we're going to say, I'm going to have my beam here, and it's going to shoot a laser, well, in this case, a ultrasound. Now it hits the cornea, it reflects, it hits the lens, it reflects, it hits this part of the lens, it reflects, and then it hits that and it reflects the sclera and everything back into the orbital tissues. Okay. So the reason why we see these spikes is because when I shoot something through it, the moment it hits something that's different, it reflects back in some type of pattern. So you see a spike because as sound goes through and it hits an interface that's different from the one it's in, some of it will reflect back, and that's what this probe is supposed to interpret, and it'll interpret it as a spike. Then it goes through the front surface of the lens, there's a spike. Then that beam because there's reflection from there. Then it goes through the lens, which is relatively homogeneous. It hits the back surface, which now there's a spike because now I'm getting reflection. Then I go to the vitreous, which is pretty homogeneous. We've talked about this before. It's pretty much the same. So there's nothing in the vitreous that's reflecting. If I had a lot of blood here, well, you'd see a spike here too, because that would not be homogeneous. And we keep going. We hit the retina. That's different from the vitreous, then the sclera, then the orbital tissues. All these are reflections. In other words, every time you see something that has a different, in this case, acoustic density or properties of acoustic quality that's different from the guy before him, you're going to get some kind of reflection because that's what sound deals with. And when you get a reflection, you get a spike. Does that make sense?
Yes.
Okay, so this is an A scan. Okay, this is an A scan. That's what it is. It's like this, not the eye on it, but just these spikes. You could erase all this and you just see this. This would be called an amplitude scan because this is an amplitude of any type. Amplitude means like kind of like the up down of like a wave here. So this is an amplitude. Does that make sense? Why it would be called an amplitude scan?
Yes, that makes sense.
Okay, so amplitude. Now, how do we get to brightness? Now, there's an old line that they talk about with brightness, which they say something silly, which is, and I never understood this until I understood it, but it's an amplitude scan turned 90 degrees on its side. And like that never made any sense to me. So let's continue this. I'm actually going to start this up right back here. Let's continue this. So here we go in A scan, and you're going to follow it. All of a sudden, they're going to shoot a sound wave. In this case, it could be a light wave if it was an OCT. Okay, it's going through, it's banging through. Now it's going. It hits that and it reflects back. Okay, now what do we do? Okay, well, I want to create a situation where I'm going to take this, and if this was like a 3D image, I'm now going to flip it over towards like this. I'm going to kind of, well, I'm going to get 216 A scans. So I'm doing it from here all the way down and I'm just mapping them out. Okay. And then here's what I'm going to do. I'm going to make them fall and point towards my screen. That's the 90-degree fall. And when I do that in all of these locations, anywhere where it touches the screen is going to be bright, and anywhere where it's not touching the screen, because there's no amplitude to touch the screen, it will be dark. Thus, we call the scan you're used to as an ultrasound a B scan. It's called a brightness scan. Does that make sense? I'm going to do this again. Okay.
Yeah.
So we're going to watch it again. And this is how you hit play. So 70,000 of these are happening a second. So every direction there's, in 1 second, it's like 70,000 of these are happening, but it's going to make 216 of these A scans from up all the way down to here to create one of these B scans. Here's the A scan. There's your A scan. So we're saying, okay, that's the representative A scan. Now I'm going to swing my probe up here, and this is what we're doing when we do a B scan, and it's going to swing around automatically, and it's going to take a scan all the way of all the tissues from here to here. There's 216 of those, and then as it falls over, meaning it's done in an instant, these 90 degrees falling, if I had a screen here and I was like, anything that touches the screen, when I flip these this way, I'll bright up, and anything that doesn't is dark, and it'll be black. And then thus I'll have a B scan. Does that make sense how a B scan is made?
Yes, absolutely.
Okay, so that's a brightness scan. Now you understand when they say you tip it over 90 degrees, now you get it. It's like I took literally, it's as if I cut out the piece of paper of the A scan and then I just dropped it down. Now, mind you, it doesn't work like that in reality. They just calculate numbers. They say, okay, well, this one's brighter. So at that point, we're going to show a bright spot pixel here. But just letting you know, that's a brightness scan. Okay, so now you understand 216 A scans, meaning 1, 2, 3, all the way down to here. If you added them up after you flip them up, that's one B scan. Does that make sense, that calculation?
Yes.
Good. Okay, so now we understood that one. So then we're going to go to another line here. A total of 216 locations, B scans, they put in parentheses, along the slow transverse direction were sampled to form a three-dimensional cube. Okay, so let's do that one. That's the statement. What does that mean? Well, now we're going from, well, I said, well, how do we get to flow? So here we are again. We have those 70,000 scans of those per second. And in 1 second, we're getting, it's not, in 216 of them make one of these. So however many 216 units in 70,000, that's how many seconds would be done. Meaning, you could do 216 would be one B scan, another 216 would be another B scan, and you do 70,000 of those scans in 1 second. So every 216, you're making a B scan. Okay, so we have that. Now, if you imagine this right here, this slice right here, okay, is one B scan. You can imagine it's being one entire B scan, like this wedge right here. So it's like one A scan, second A scan, third A scan, all the way up to 216, and that forms one kind of two-dimensional B scan right here. So let's then go ahead and go like this, and you see this is sweeping across the transverse plane. You cut the eye in half, it's sweeping across. So do you see how I would form, if I added all that up together, like a cube or like a three-dimensional, if I added all of those scans together as I swept across? Does that make sense?
Mm-hmm. Yeah.
Okay. And so if you imagine this is one B scan, then the second B scan, third B scan, all the way up to 216 of those. So 216 B scans create one of these cubes. Okay. So remember, you can go this way, or you can go this way. It doesn't really matter, right? But you're still getting all of the information, right? So that's the cube that's being given. Mind you, when you're doing a B scan, you're kind of actively doing this yourself, right? But if I had like a way to show you all of the 3D images, you would just get a perfect cube, or, you'd get the whole 3D of the eye if you swung it that way, okay? So we swing the probe around the transverse plane, we get multiple B scans to create that three-dimensional image. So now we understand what a total of 216 locations, B scans, across a slow transverse direction were sampled to form a three-dimensional data cube. It makes sense. It's just from one side to another, I swept the two-dimensional probe. I got all the B scans in each of those locations, and it just so happened to be 216 that they chose of those locations as they swept across. Okay, now we say 5 consecutive B scans were captured at a fixed position before proceeding to the next sampling location. This is key for OCT angiography or any type of angiography. So what does this mean? Okay, we're going to now actually go and now we're converting our brain and we're saying, okay, instead of it being an ultrasound, it's going to be just the cross section cube of the OCT. It's the same idea, but let's go and see how this works. So here we go, and I'm going to show you. So you see there, okay, and there, and I'm going to move back real quick, okay? So first, imagine each one of these lines is an A scan, okay? And then imagine as I do one of these, okay, one entire slice here would be a B scan because, and imagine there are 216 of these A scan points, right? Amplitude scans, and I make one slice right here. This is one B scan, just like we talked about, except in this case, it's light doing it, okay? Does that make sense why this one slice would be a B scan here?
Yes, it does.
Okay, so now what we're doing is we're going to do, in this case, we're doing 4, but it said in our note 5, but we're doing them in the same spot. 1, 2, 3, 4, 5. We're doing like 5 B scans, or in this case, you'll see 4 B scans immediately, like, and you're like, why are we doing that, right? So let's see what's going on here. 1, 2, 3, 4 in this case. 1, 2, 3, 4. What's going on here? Why are they doing this? So they're going to show you when we zoom in 1, 2, 3. This is the A scans. Here's the second B scan. And then here's the third B scan. And then here's, in this case, the fourth B scan as the blood is going across. Now we have 5 of them, but notice what happened when we did 4 in a row. Okay, let me move it back, all the way back here. Okay, I'm gonna just do this guy again. Actually, let's start from the beginning because it's easy. It's now that you get it. Okay, so first B scan, second, fourth. Okay, there's 4 in this one. Well, okay, 1, 2, 3, 4. Okay, now we're gonna zoom in and see what's going on. Okay, that's the first B scan. These are each individual A scan lines. Here's the second B scan. Here's the third B scan. And here comes the fourth B scan. And in our case, we do a fifth. But notice how each of those B scans would have caught those blood vessels, those blood cells in a different location, right? So the first B scan in the same spot had no blood cells, I think. The second B scan had 1 blood cell that one of the A scans bounced off of. The third one has another, the blood cells have moved across the frame here. So you see it in a different place. And the fourth one is a different one. So in other words, when there is something moving in a particular location, if I take multiple photographs of that image, of that same spot, multiple B scans, if there's a change between each of those B scans, that means I assume there was motion. And if there was motion, I assume there was flow of blood because that's the only thing that moves in the retina. Does this make sense?
Yeah, it really does. Okay.
Now, mind you, now you're getting, once you understand what's going on, now you understand like, where could there be some confusion, right? Like, what if I like moved my head, right? Like if you move your head in the middle of one of those B scans, like you could do 5 in a row, but between second and third, I just moved up a little bit and then came back to it. My head moved, that would be interpreted as flow. You see what I mean? So that's one of the kind of drawbacks. And I'm just saying, once you understand the science, then you understand the drawbacks, right? So let me see, how do I get out of this? Yeah. So now we understand, we understood then what this meant with, what did I say this? 5 consecutive B scans were captured at a fixed position before proceeding to the next sampling location. You saw one where there was 4, but now you understand what 5 consecutive means, okay? Now, here's the last one. With a B scan frame rate of 270 frames per second, the 1080 B scans in each scan sequence were acquired in approximately 4 seconds. Okay, that's what they're saying. So let's go through this because we make sense. We'll build it up from where we started. Each A scan was taken 70,000 times per second and, average. Okay, 216 of those A scans are then combined to form a B scan. We know what that means now. 216 of those B scans are then swept across the transverse plane to create a 3D image, like we talked about. And then at each B scan location, by the way, 5 B scans are shot in that small area. As we saw, our movie had only 4, but you can understand that it could be 5. So in this case, it was 5. 5 have been shot in that one area at the same time, bang, 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 to determine if anything has changed. If so, they'll mark it as having flow. And then thus 5, if we do it like that at every 216 B scan location, we get that 1080 number that they said. And so since they do 1080 B scans in total, and it's done at 270 frames, another word for frame is B scan, okay, that's a frame, per second, therefore it is done in approximately 4 seconds because OptiView wants to flex in public and say how fast it is. Okay, that's the company that does it. So my broader point to you is now you understand what they're saying. I mean, it's a dense paragraph, but it completely makes, at least I hope so, it makes sense both mathematically and like what you're doing, right? So let's, what is OCT angiography then? It is simply a bunch of OCTs. Okay, remember when you look at an OCT, it's a B scan. That's what it is, but it's of light. It's a cross-sectional analysis. And now you see, why do you get better resolution? Because light has a smaller wavelength. And so when it has a smaller wavelength, it can fit itself into little bitty parts, and like we talked about, the reflection between tight junctions, blah, 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 like we talked about before, hyperreflectivity. It can do that. Sound can't. Sound does not have that ability to have that level of resolution, although sound is amazing. It can show us other things. But the broader point is, this is just a bunch of OCTs shot in a single place really, really quickly to see if the last scan is the same as the initial scan. And if it is not the same as the first or second or third or fourth or fifth, if they're not all the same, then we presume that the sole thing that caused the change is a flow of an RBC through an artery or a vein. Then it moves to the next spot. The OCT angiography does the same thing and on through the area of interest. So here's I think it was Dr. Spade. Here's the vascular layers. This is one thing we can get out of it, this depth perception. But notice over here, okay? There is no flow that should be between Brooks and the outer plexiform layer. There shouldn't be any. There's no vessels there. Where do they get their nutrients from? We talked about this last time, the choriocapillaris with the diffusion, and that's why we have that outer blood retina brain barrier. Remember that? With the tight junctions between the RP cells. You remember that, Giselle?
Yeah.
Okay, so we know that there's no vessels there, because it's getting its nutrients from the choriocapillaris that's diffusing through here. So what would happen if you saw flow here? You would say that's pathologic, right? And so that's how we use this. We say, well, look, OCT angiography shouldn't have flow in this outer nuclear layer, in this area, RPE, subretinal. But if I see flow, then I'm presuming, hey guys, is there like CNV? Is there neovascularization? What's going on there? That's how we use this, okay? It's not perfect, that's how we use it. So I say if there is flow between the outer plexiform layer and Brooks, basically, then it's presumed to be pathologic and we think indicative of CNV. Of course, the limitations, as I've said, constrained to the optic nerve and macula. Let's go through a quick clinical example, okay? Here is what one of our OCT angiographies can look like. Now, we have a pretty cool one. I like this one. Some of them are different. They only give you on FOSS images. Let's look at this one. It's just a little bit easier. The first thing is you say over here, which I've highlighted, that's your traditional OCT. You know that. Okay, so identify the traditional OCT first. You see if there's any pathology. Well, yeah, there's pathology. This is exudative AMD. I'll just tell you, you can see, right? I mean, this isn't normal, right? We have this weird stuff here. Okay, so then you say, all right, now I'm gonna look at these cuts. Now, these cuts are what are called en face. It's almost like the fluorescein angiography, except we're not doing fluorescein angiography. We've done the flow thing, right? So we light up places where there's vessels because that's where flow is actually really heavy. And then the other places where there's not lighting up here, where we're kind of showing you this, and it turns out that it follows the pattern of the vasculature, which makes complete sense. That's where all the changes you would see are, right? So we have this, and this is basically showing us an en face sort of OCT using OCT angiography. And then you look over here, this is your traditional type OCT angiography, and then both are OCT angiography. This is still OCT angiography because you can see the vessels light up, right? But it's not telling you depth. I mean, you have to go through each one of these cuts, but this one's your traditional type, which gives you flow with these red spots. So let's go through really quickly. I'll say, okay, which one do you look for? You start with the en face. I say, okay, let me look at the en face. Let me look at where that is. That says it's the superficial. You start at the top left, the most superficial cut. Then you identify where that is in the traditional OCT. Don't just look at the layer and say, oh, I know where it is, because sometimes it doesn't correlate. So here it says, this is up here, top left, superficial, which means ILM, internal limiting membrane, minus or between internal limiting membrane and inner plexiform layer. I mean, now in your head, you're like, yes, I remember that, right? Mueller cell foot plates coming together. Okay. And then IPL, inner plexiform layer. Plexiform layer is the light layer. So it's between a line and a light layer. I think if we can talk like the way I described it to you. So we say, okay, that's kind of like over here, right? That's where this is supposed to be. Okay. So then we continue iterating, right? Okay, here's deep, IPL minus OPL. So between inner plexiform layer and outer plexiform layer over here. So we say, okay, where is that on the lower right? It's right here, right? The two light layers. the inner plexiform and the outer plexiform. You know, it's hard to see because it's pathologic, but you notice, right, that's where that is. Now we do the same thing over here. This is supposed to be the outer retina, which is the outer plexiform layer between that and Brooks. That's what it's saying. But let's draw that line here, right? So you can see here, if I draw a line here, that's between outer plexiform and Brooks, what they call Brooks membrane, which we know is the RPE Brooks complex. You see it's supposed to be between here, but if you look, this guy's showing up. Why is he showing up? Because if I took a slice through it, I'm actually catching it. Do you see that, Giselle?
Yes, absolutely.
Right? And so you see this network and it's lighting up because it's still angiographic. Okay, this is not a fluorescein, but it's lighting up because we can see the flow and it's showing it as a lighted up layer here. Okay, and so that's great. So we see that, and there's your cut there, and that's corresponding to that. So you flip it around. If I were to look at it on FOSS, that's what it would look like from above if I took this sliver through here. And then finally, and then if you look, here are the areas of red which are showing in the cross section red, which is flow. Now I'd expect it up here because this is where the retinal vasculature should be, and this is where the deep capillary plexus should be. But if I look here, there shouldn't be stuff bowing into the retina and having these red areas. This is flow that's happening because we did multiple B scans through this location and there was a change in our image, and we presume that any change in those areas is going to be flow. And so we're showing flow, 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 flow. It must be that there's some aberrant vasculature growing here, right? And you see those areas over there. And then finally, we look here, choriocapillaris. That's here, but notice how noisy the choriocapillaris is, right? Makes sense why it would be noisy here, right? Because you see, obviously, there's capillaries there, right? So you can't then say, oh, well, this is pathologic because there's red, and I can't say this is pathologic because there's red, because I expect that there's retinal vasculature here, and then there's choriocapillaris vasculature here. But I can say that if I have a slice like bowing in or something weird like way out here, something like that, there's not supposed to be flow in this area. So we got to say to ourselves, that's pathologic. That's the idea, okay? So there you go, and I'm showing there's a vascular type 1 CNV is what we call this. I'm just telling you that, okay? So that's just a run through of this, okay? I hope this is helpful. It at least explains what you use, right?
Absolutely. Absolutely.
Okay, cool. So that's just kind of a segue. And then next time we have something, there's no reading or anything like that. We're just going to go back to the circuitry of the retina. But I usually start with this, but I wanted to do OCT first, and then you get this, and now we can go back. Okay.
Yeah, this is really great. Thank you so much.
Awesome. No problem. Okay.
All right. Have a good night.
You too. Bye.
Bye.